Welcome to the Low-Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor. Welcome to the Low Carb MD podcast. I'm really excited about this one. This one has been in the works for a number of years. I have followed Dr. Stephen Palter on social media. If you haven't, you should right now. His TikTok videos have over 200 million views. He's on Facebook, he's on Instagram, YouTube, at Stephen Palter MD. He has an illustrious career. He's the founder and medical director of Gold Coast IVF in Woodbury, New York. He is a fertility doctor. He happens to be the fertility doctor who I send all of my local patients to. He is a member of the faculty at Yale. He was the clinical chief of Reproductive Endocrinology and Infertility. He's founded several programs there, including, just very interesting high-tech stuff, including endoscopic surgery. He's a techie like me. He was the first editor for video and news media for a fertility journal. He's been published over 80 times. He's a father of three, and he's a small business owner just like me. So I am just absolutely ecstatic to have Dr. Palter here. Finally, we got you in.
We've been trying for years. Thank you for the intro and the kind words. And I am a huge Tro fan myself. You've guided me and my patients. We've had amazing collaborations on metabolic health, and the insights from you have really changed both my personal and professional life. And the overlaps between metabolic health and fertility and women's health, and the overlaps between sort of the things you struggle with in medicine and we struggle with are just so similar. It's just so similar. So I'm delighted to finally, we made the time to be here together.
Yeah, so I always like the origin story of how people got into medicine, how they got interested in sort of metabolic health, and how they were first exposed to, So where is your origin story? What made you become a doctor? What drove you to the field of fertility? Where did your interest in healing and where did that all begin?
Yeah, no, thanks. It's interesting. I get asked that online sometimes. People are like, why did a guy become a gynecologist? Why did you become a fertility specialist? So I am a board certified both OBGYN and reproductive endocrinologist in fertility. It's a subspecialty of the field, and I'm double board certified in both. I always knew I wanted to be a physician from the time I was in junior high school to high school. I was actually doing research on medical research when I was in high school. And I actually applied and was accepted to medical school while I was in high school. I went to the 6-year medical program at Boston University because it allowed me to get accepted as, 17 years old. I got accepted to medical school and I finished college in 2 years and was fast tracked to do so because there was a lot of things I knew I wanted to do. I went to school 12 months a year. We made up all the credits in the summers. But it was a fast program. And I was always interested in behavior and hormones and the brain. My father was a clinical psychologist. He trained with someone who trained under Freud, and he had that lineage. And I thought I was going to become a neurologist or an endocrinologist. I was fascinated with endocrinology, sort of hormones, this thing coursing through the body that affected behavior. And I showed up in med school, and first day I'm like, I want to do research. I want to change the field. And I went to lectures. I wanted to be the guy giving the lecture on the cutting edge, guiding people and bringing new knowledge. But I hated diabetes and thyroid and chronic illness because what I saw was that they weren't fixing anything. The patients weren't listening to them. They weren't compliant. It was just like checking boxes, telling them what to do. They didn't do it. They had nothing to offer. They gave them insulin, and it was chronic disease management until the patients died. And I was like, this is a nightmare. And I love this high-tech stuff. And I'm like, what am I going to do? And one day I'm on my OBGYN rotation and OBGYN surgical. And we're in the OR and I see laparoscopic surgery where they put a telescope through someone's belly button and they do keyhole surgery with a laser and they repair stuff. And the woman got pregnant. I was like, oh my God, what is that? but what happens about like all the stuff I love with behavior and all that? And they're like, oh, well, we also do all the reproductive stuff and we do fertility and we do all those hormones. And so all the people I was doing research with were like, you actually should become a reproductive endocrinologist, not a medical endocrinologist, because what infertility does is we have the most motivated patients on earth. They will do anything. They'll cut off their arm to get a success. And it is cutting edge. It changes every year. What we did was obsolete from, the year before was obsolete, and it combined all the best things and you change people's lives. So that's kind of how I got into the infertility world. I did my residency and then I went to Yale for my fellowship and stayed on as a faculty member.
There's a lot of parallels that you just said, with the infertility population and the obesity diabetes population. When you're talking about behavior or mindset, one of the things you just said, which caught me, was, and I have, patients who struggled to get pregnant, and just like I've had patients who've struggled to lose weight and patients who struggle with diabetes, they're a very sort of vulnerable population. You said something that I say: when I was 350 pounds, I would have cut off my pinky to if you said, you have to cut off your pinky to lose 150 pounds, I would have done it. Right. And you just said it yourself, these people are coming to you and they're so motivated because they want to be a parent. They want to experience that joy of becoming a parent, having a kid, and they would cut off their arm. So it's a very sort of vulnerable group. So, and which I think takes special consideration if you're going to deal with that population.
You have to like that because, there are people, if you don't want to partner with your patient, and this is a life, you can't look at them an isolated ovary or an isolated sperm. Their whole body affects this, both mind and body, not only in terms of success, but in terms of not killing them with the treatment. So there are patients, 50% of patients drop out of infertility treatment elsewhere because the process is so emotionally and physically devastating to them. But for us, we empower them and they come out healthier, better at the end. They don't drop out, and they're part of our family for life. They come back and visit every year, and they feel transformed. They are better parents having gone through it. They say that they are better because we transform their life, and that's because we partner with them as a whole person.
Yeah. So what I want to hear about. So here you are. You're interested in sort of behavior. You're interested in helping people. You're interested in hormones, and you find this field of fertility as a young doctor. And can you tell the average person what that's like? They don't know what becoming an OBGYN fellow is. They don't know what it's like to go and get advanced certification in reproductive health and reproductive endocrinology. They don't know what it takes to sort of help people on the cutting edge of fertility. So can you walk the listener through that journey?
Yeah. So one of the difficulties is any OBGYN can call themselves a fertility specialist, but they're actually not trained or boarded in it. And there are three major things. A lot of things can cause infertility problems, but they're hormonal, the man, the woman, the woman's anatomy. And so, about a third of infertility is the male, a third is the female, a third is combined. And, the training that I did, I spent 4 years doing OBGYN. So we had to learn to deliver babies. We were working 120 hours a week. I did shifts back then where I would start at 7 a.m. Friday morning and I didn't go home till 6 p.m. Monday night. At the end, I was hallucinating from lack of sleep, 72 hours without sleep, delivering hundreds of babies, doing surgery. And what I saw was there were people that just wanted to do hysterectomies and deliver babies. And I just wanted to make the baby. So I would stay after when I was supposed to go home to do the infertility surgery in the cases. I was doing research at night. And when I finished that for 4 years, I applied for another 2-year fellowship where we had to do a whole year of research and a whole year of both surgery, hormones, and in vitro fertilization. The test tube baby transformed our field. That started in 1977. Now there's over 8 million babies. So in the past, we couldn't fix things. Success rates were like 10% for women. And now, over 90% of people who want to have a baby can have one. And so we can either fix their anatomy, we can fix their hormones, or we take the egg out of their body, join it to a sperm, genetically test it, and help them achieve a pregnancy. So it's just a lot of training. And I trained in a program. The reason I went to Yale, I was recruited by sort of half a dozen different programs in the country for my fellowship. I was really fortunate that I was an in-demand candidate. Yale was the one where they said, we're going to teach you the hormones, the surgery, and the IVF. I wanted to learn it all because I didn't want to be just a one-sided doctor with one tool in my tool belt. And, that's why I went through that kind of training, and that's sort of where the field has gone.
So, it's interesting. I know there's a lot of crossroads. We've had a number of patients who've worked together, and I can tell you, we have like it's funny. I tell all my patients we have a bell here when that we ring. When companies make a big sale, they ring a bell. If they make a big sale, we ring a bell if somebody reverses diabetes, reverses obesity, and we rang that bell together on a patient that we had, and then I cannot tell you that. So we have a joy in that, we have a pride in that. But when I got the message, from that patient who later became pregnant, it just brought an even greater joy, to me. And I know you probably get to experience that day in and day out. And I know you probably can't say it, but to have one of the highest success rates in the state and maybe the nation, I think speaks to your work ethic. Can you walk me through what I'd like to talk about here is, to what degree is nutrition, metabolic health, part of this fertility discussion? So I'd imagine you're seeing people somewhere between, 20 to 40, plus or minus, and they're going to have a myriad of issues, hormonal issues, anatomic issues, like you mentioned. To what degree do you think metabolic health plays in the modern infertility sort of epidemic? I know technology is sort of, really expanded, success rates have improved, but to what degree is nutrition a part of this plan?
It's astronomical and more than ever. And part of it is the same things that are causing your problems are causing ours. So if you look at, as I said, it's the 1/3 male, 1/3 female, 1/3 combined. We have pregnancies up to age 55. We can get postmenopausal women pregnant now. We actually have that technology. But when you look at the major causes, lifestyle things and life factors and environmental factors are responsible for an enormous amount of infertility. Infertility, when I first started, they used to say, 1 in 12 people, then 1 in 10, 1 in 8. The new statistic is 1 in 6 couples will struggle to get pregnant. And the reason why that number is going up is lifestyle things that have changed it. So sexually transmitted diseases cause blockages in the anatomy. Aging in the woman.
Talking about HPV and gonorrhea?
No, not HPV. It's chlamydia, gonorrhea, the number 2. Chlamydia is asymptomatic in women. It's epidemic in colleges, and then it causes a blockage. Number 2 is aging of the woman. So at age 20, 80% of your eggs can cause a baby. At age 40, only 1 in 5 can. Only twice a year that woman releases a good egg. Smoking, huge effect. But the epidemic one that's rising is obesity related. It's a disorder called polycystic ovarian syndrome that is a hormonal and weight related condition that is probably one of the most severe diseases in the world now that gets just a fraction of the attention it should. So if you look at causes of, how does weight and nutrition affect fertility? And it's not just for fertility. For people here who are listening, any woman, their health can be impacted reproductively by their weight, because the interplay between weight and hormones in the menstrual cycle that changes your life from puberty to reproduction to menopause is enormous. So 40% of infertility is not ovulating, not releasing the egg. And 80% of that is this disorder called PCOS. And those women, it was first started in like the 20s, the first time they found it, they called it the bearded diabetic woman. These are women who have excess facial hair, they're obese, and they're diabetic. And now we know that there's versions where you don't have to have all of those features. You can even be slim, but insulin resistance is a major portion of the onset of that disease. And the rate of this, it was originally thought to be 5% of the 5%. Now it's of the population. Now it can be as high as 20% in some studies. And that's all weight related. That is all overnutrition. And these women develop diabetes.
Yeah, it's I find it embarrassing. This is again coming back to a vulnerable field. If you are handling PCOS in a standard clinic, certainly, saying that you should, sort of lose weight and exercise is a part of the plan. I'm not sure we really coach people to do anything about that in a sophisticated way. But the mainstay of treatment, and you can tell me if that's changed, and at least from my angle, what I see is metformin and spironolactone. It's like, let's just put you on this drug that sort of helps with the hormones, and put you on another drug that improves insulin resistance. And, it's like, that's the magic pill for PCOS. And yet, time and time again, we see patients who, are still, experiencing, significant symptoms and infertility. And I feel like they're getting a Band-Aid approach.
Well, that was cutting edge 20 years ago. And we fought to say, wow, there's an association between insulin resistance, weight, and PCO. And that is ineffective treatment. That really should not be that treatment barely works and is like third tertiary treatment. And unfortunately, healthcare for women is not good in a lot of parts of the United States. There is a whole host of reasons. Part of it is the way OBGYNs are trained. They're trained mainly to deliver babies and to remove tumors. And they don't learn the subtleties of infertility. And part of it is blaming the patient. I saw 2 consults yesterday where the patient like 6 times said to me, "Thank you for not fat shaming me." Like, that's all she said. And they're just told, oh, well, lose weight and, eat less, move more. That's the instruction that they get. And this woman said, well, they told her, well, when you just lose weight and you'll get better. And that's what happens is these doctors think it's due to being fat. And then they say to them, just lose weight and you'll get better. And they don't get treatment. So the treatment, the relationship between insulin resistance and why metformin is used and the relationship to fasting and ketogenic diets is such an overlap with what you do. What we learned when I was a student, I was in a research lab and they were doing work and they showed that insulin and insulin resistance drives the ovary to make male hormones. So what is PCO? I think people need to know what it is, regardless of whether you're trying to get pregnant or not, because your daughter, or your neighbor is going to have this. And if your patients are overweight, the rate of them having this can be up to 80%. And so what happens is, what they share is they overproduce male hormones and it blocks them from ovulating and releasing their eggs, and they have insulin resistance. And the insulin resistance drives the male hormones to get worse. So what does this woman experience? Well, they're overweight, they have really bad acne, they have maybe some facial hair, they're obese, they feel they can't lose weight, their period never comes. It goes month after month after month, and then all of a sudden, that's because they never release their eggs, so they don't ovulate, so they don't get a period, and then the lining of the uterus breaks down and they hemorrhage. And so I see patients who tell me for 5 years, the average patient with PCO has seen 4 doctors and been to the ER, and nobody ever made a diagnosis as what was wrong. And this is like a first-year med student should know this. And then they tell them, well, just lose weight and you'll get better. It's your fault. And so metformin tries to reduce the insulin. It's an insulin sensitizer, as you know, but it's really third-line therapy now. Spironolactone is a really weak male hormone blocker, not a good treatment either.
Yeah, and I think that token sort of statement from our colleagues is what sort of upsets me the most, which is, you got to fix your diet, go exercise, and lose weight, right? And yet, do we empower people with tools to make that happen?
Right. They come and they apologize to me for being overweight and say, I've tried everything, I can't lose weight. And I'm like, well, did they tell you how to do it? And they're like, well, no, they just told me I had to do it. I'm like, well, they never gave you the tools. So if you had high blood pressure, they'd give you the tools to fix your blood pressure. They're not giving you the tools to fix your ovulation or your weight. And then they're blaming you for having it. And then they feel shame. And these women feel like they can't be a mother, they can't be a woman, they can't have a relationship, or they're bleeding out and they're obese, they don't feel attractive, and we're failing them. And even the fertility doctors now, so IVF is a great treatment for this, super high tech, but super costly for many. And then instead of treating the root cause of their problem, like, well, we'll just do IVF, and then it fails because you didn't treat the PCO and the insulin resistance. And so we're just putting Band-Aids on this as opposed to treating the root cause. And part of the reason why our success rates are so good is we start with, like, what a concept. Our process, our success spiral, we have a process that starts with actually making a diagnosis, actually looking for the root cause and doing the tests. And people will say, well, I had all the tests and they found nothing. No, your doctor did 2 tests that are 20 years old. They never looked at the results. The results were wrong. They never looked at the imaging. Oh, the imaging is normal. No, I look at the x-ray and 20% of the time it's wrong. So by looking at the information and then making the diagnosis, you tailor the treatment. And then a shocking thing, what do you do when treatment doesn't work? The standard is you tell the patient it was bad luck, do the same thing over. And they do it over and over and over. Whereas we say, what did we miss and what did we learn? And let's reanalyze all your data and find what was missed.
I want to talk about this because you know, before we came onto this podcast, I talked about how I think this group is a very vulnerable group, the infertility group, very much, the obesity group, diabetes group. It's a very vulnerable group because there's a lot of blaming the patient, right? And they're very vulnerable because they want to get care. They want to improve. I haven't met somebody who had a fertility problem who didn't want to become pregnant, right? They wanted it. They desperately wanted it. They would have done anything. So if you look at sort of what you just said, which is, if you look at the system and how doctors are rewarded, they're rewarded based on the amount of times they attempt IVF.
Right. It's
right.
You're paid per try, not per success. And I will say to patients, it took me an hour. My new consult is an hour with a patient. If we have a failed treatment, it's an hour of analytics. And I'll say to them, it would have taken me 5 minutes to redo this. And so what's happening in our field, if we didn't look. So what's happening is there's, corporations are buying medical practices, their private equity is rolling them up, and all they want is volume. So they'll put like low-level providers that have barely any training. They have protocol driven, do the protocol, do A, B, C. And the more they do, the more they get paid. And it will take me 2 hours to figure out what's wrong and do no procedures, but I'll get to the right answer and we'll do the right one the first time. And medicine is unfortunately in a lot of places going to protocol-driven, no thinking volume, as opposed to intellectual, excellence and success.
I think this is a huge problem, particularly in issues that require sort of complex thinking and thorough, comprehensive care. And the field of weight management, I think, is one of those. Diabetes is another one. Heart disease is another one. Certainly cancer is another one, and fertility. I think, if I have, an upper respiratory infection, I'm not really, I want quick access to care, but if I need help with fertility, I want the best. If I have an issue with diabetes in my family, I want to send them to the best. If heart disease, I want to send them to the best. So, what I've found is, it's a very vulnerable population exposed to multiple sort of reflexive procedures, sometimes unnecessarily, and a lot of times they're exposed to sort of hormonal treatments, almost reflexively, and the basics aren't being met. And what you just described, spending an hour or an hour and a half to go over the work that somebody else has done, go over the labs that somebody else has done, that's one of the things I've been so inspired by. When I watch your TikTok, all you do is basically go over these complex cases that mysteries to other people that were so easy and so not easy, but I shouldn't say easy. Were easy for you because it's clear that you're masterful at your craft. So how do we change this in our modern?
In medicine, it started when we started. In my training at Yale, we had to solve problems. If you didn't know a fact, if it was Saturday afternoon, if we had patients, 7 days a week, and if my mentor called, I was the fellow and I presented the case. If I didn't know every lab value and everything she had done, he'd say to me, go back to the hospital and call me when you have the results. And it's like we wanted to solve the problems. And you have to have that questioning idea. And we were also responsible for everything. So the buck stops with me. I'm responsible. If everything's done by a committee where no one's responsible and everything's done by a protocol where nobody thinks, you're going to fail the system. My parents passed in the last few years. There must have been a dozen times, they were in their 90s, where they would have died in the hospital had I not caught medical errors. And the errors were people just assuming something was done or not looking for a cause when things didn't make sense. So I knew nothing about heart disease. I knew nothing about kidneys, but I was like, what's the result? What does this mean? And how do I learn? And I think this can empower your patients. The patients are now doing this on their own. So when I put in my TikTok a mystery case and it gets 1 million views in a day, I get 10,000 comments of patients saying, this was me. And going to my doctor and telling them to test me for this. So what does the patient do? Well, your patients, your people, just by being on this podcast and following you, are learning the questions to ask. They're learning the patterns, the diseases. And so half of my patients are patients who have failed elsewhere. They come from around the world. They come in and they ask, the more they watch, the more they learn, the best questions that they ask. But what I say to them, first question I ask is, oh, you did this treatment. What diagnosis did they give you? They didn't tell me what was wrong. They just said it's not working. Okay, when your treatment failed, what was the reason for the treatment? They didn't tell me. They just told me do it. What was the success rate they told you to expect before you start? They didn't tell me. When it failed, what are 5 possible reasons they gave you it failed? They said, bad luck, do it again. So for any part of medicine, if you're told, do X because I said so and the protocol said so and it didn't work, it's your fault, go somewhere else. If the doctor says, let me discuss with you all the reasons why, and together we'll choose what's right for you, and if it didn't work, let's figure out what we could have missed, you're going in the right direction.
Yeah, I think, I've said this so many times. I remember lecturing medical students, and, I asked them just very simply, and we're both fans of technology. I said, everybody had a stethoscope around their neck. And I said, well, what's the purpose of the stethoscope? And they all answered to listen to the body and, and imagine what we're listening to. I said, well, why don't you all have ultrasounds? Why isn't every single medical student being given an ultrasound? Just think, don't just do what the people before you have done. Question, is there a better way? What can I do better?
Right. So when I went to Yale, my mentor, one of the reasons I went there, I said to him, I was being recruited at these different places and they were telling me what I was going to do. And he said, whatever you want to do, I will enable you to do it. And I want you to do it better than I did it. And I went and gave a lecture. I was on the lecture circuit as a fellow. I mean, I was 20 something years old. I was going around the world. I was training people who I had been interviewing with the year before. Now I was training them. And I was in Japan. And I introduced a new technique and they said, we can't do it. And I said, why? And they said, well, because the senior professor doesn't know how to do it. And until he does it, we can't do it. It's shameful. And so I said, well, when will you be able to do it? And they said, well, when he dies. And so, I left Yale. And so I worked there. It was an amazing place. And I worked there because we were pushing the cutting edge and we were doing research. But it got to the point where my whole department were basic science, rat researchers. And I was the one taking care of the patients. And I wanted to start a center where we could be holistic and treat them with compassion, success, and the cutting edge. And, when I left, the first thing I said was, I want to challenge everything that I've done for the last 7 years and find out where I can be better. And I called 100 people in my field and said, tell me how you do this. Tell me how you do this. Tell me how you do this. I want to learn and be different than what I did yesterday. But I see these second opinions and they're like, the doctor will never consider another approach. That's a bad sign. I know with you, we've talked about cases. You're always like, I don't know about that. Let me look that up. Let me find it. Let me try something new.
Yeah. I think, it's interesting also, the information changes. So, somebody was asking me, well, how strongly do you feel about low carbohydrate diets? And I said, well, it depends on the population and, what's going on. They're like, well, what do you mean? And I said, well, look at the United States population. On average, they've gained 40 pounds, right? On average, their cholesterol has dropped over the last 40 years. Their LDL has dropped, but their triglycerides have increased. Their HDL has dropped. Their weight has gone up, and their A1Cs and fasting glucose has come up. So in our modern world right now, if you look at right now, and the observational data matches up with this now, low carbohydrate diets seem more favorable in the newest, largest, biggest sets of data. And that the truth of the matter is 50 years ago, it wasn't the same population. It was a much leaner population, much more metabolically well population.
Oh yeah. I mean, you look at, things from the 70s, Archie Bunker, who you thought was this, hugely obese person, would be considered, you look at a picture of him, he looks slim today.
Yeah, I mean, so the thing is that things change, right? The etaologies of our problems change over time, even in our own lifetime. And we don't have the luxury to say, wait till I die for me to change. Our population is changing. The insults to our metabolism are changing so quickly. The reasons, I'm sure in the fertility, that there, for example, this is just one of the things I know, the offspring of DES is what caused a lot of sort of malformations. Well, the incidence of that has probably come down, right? And other things rise up. Maybe HPV or chlamydia or gonorrhea, are now on the rise, or maybe they're treated more aggressively. So these things change, and we have to be able to adapt. Do you find that among your colleagues that there's been, this eagerness to adapt? And where do you think that the innovation is coming from?
I mean, one of the reasons I went into this field it is one of the most rapidly advancing one, and one of the ones that is most akin to innovation. But the resistance is everywhere. If you look at laparoscopic surgery, the keyhole surgery, I mean, I trained in that. I was a fellow, I was developing new procedures. But the first person who took an appendix out through a telescope without an incision, when he did that in Germany, I worked with him. They made him get a CAT scan of his head because they said, you're obviously have a brain tumor, and they tried to arrest him. The people in the US that I learned from that did what is now considered cutting edge surgery, they try to remove, every one of them tried to have their medical licenses revoked when they did a procedure that was better, proven better, but other people just didn't believe it. When I did my first procedure, some of these things that I presented it at a conference, they said, I commend you not only for doing this, but for doing this in an academic center where progress usually isn't made. And my mentor used to say, you have to have an open mind, but not so open that your brain falls out. And so what's changed, the patients now can see this. They can learn. It used to be we were the gateholders of information, and now online patients can find out instantaneously information. And the doctors are in two groups. There's the minority that are open and willing to change, and the other ones that just sit on their laurels and say, like, that's the way I learned it, it'll never change.
I think it's a tragedy. Can you walk me through, I want to step back into PCOS. We talked a little bit about nutrition. I know I've seen a lot of the data, and we've exchanged some papers before. It seems to me like we can start to say that there are ideal nutritional therapies for PCOS. I know some universal truths like weight loss does help. I'm not going to disregard that. There seems to be some evidence that, some modest amount of caloric restriction does help. But can we talk about the hormonal impact of, low carb diets? Will we see a lifetime where low carbohydrate diets are first line for PCOS? Is that the case? Do you think there's evidence to support that now? Or?
I think there is evidence to support that carbohydrate restriction should be primary treatment for PCOS, but the resistance to this is astronomical. And the same reason you see the resistance of people doing it for heart disease and treatment. So here's part of the confusion. So PCOS is epidemic, it's increasing. It is the reason why young girls are going through puberty earlier. It is the main cause of uterine cancer as women get older. It causes cancer of the uterus when you don't get your periods. It causes infertility. It causes weight gain. It causes acne. So this affects you at every part of your reproductive life. And it's even been shown that it affects the children in utero of the women who have it. But it's a group of disorders. It's not just one thing. And that's what's made the research so bad. So they all share this commonality, but some people are skinny and some are overweight. And so there's different things that make it happen. But the truth among all of them is 80% of the overweight people with PCOS are insulin resistant. 30% of the lean form are insulin resistant. And the high insulin causes the male hormones to go up that makes the disease wrong. So literally, my mom was a patient of Dr. Atkins in the 80s, and I heard this, and I'm like, well, if insulin drives up your blood sugar and insulin drives up male hormones, then what lowers insulin? Not eating carbs. It should help this. And so I tried to do a study with this with Atkins actually in the 80s. And he was like, yeah, I see this in my PCO patients. They get better. I was like a med student or a med student back then. We were in high school when it first started. And so the debate is, the problem is the studies are so bad. So the dogma is take a Mediterranean diet and lose 5 to 10% of your body weight, and that will help your PCO, and then take drugs. And then they say, well, but take metformin because it lowers your insulin, it improves your insulin resistance. So if you were treating a patient that's overweight and pre-diabetic and they were insulin resistant, you'd cut out their carbs. So there was actually a landmark study published yesterday in the Endocrine Society that was a meta-analysis of 7 studies, 200 women, and they showed that a carbohydrate restricted diet of less than 50 grams or under 30 grams in some of the studies dramatically improved testosterone, it improved the pituitary hormones, and they lost 10% of their body weight. They did it, some of them, in 2 or 3 months. So the data is there. But when you go to our meetings, there and social media, the fertility doctors say, be vegan, meat is dangerous, and eat a Mediterranean diet. And they've abandoned this idea of ketogenic because they don't understand keto. They don't understand carbohydrate restriction. They say it's an unhealthy diet because it causes heart disease. It's not sustainable, and it's not good for you, and nobody can do it. And then when they do it, they look at this keto, and a lot of my patients look at keto online, and they're like, oh, I have to eat fat bombs. I have to drink bulletproof, put butter in my coffee, and I have to eat 80% of my calories from fat. And then I have to eat keto ice cream and keto treats. And I did all that and I gained weight, so it fails. We put patients on your version, and we've talked, the way we prioritize protein. We tell them cut your carbs down under 30 grams if you can, under 50 if you can't. Eat only when you're hungry and eat a full meal. Don't snack. Do not the dirty keto. Don't eat keto treats. And fat, you can have fat if you need it, but don't make it what you're pushing. And our patients, whether they lose weight or not, they improve. I had a patient who I saw she came up from Florida.
It's interesting you say that. I'm sorry to interrupt you.
Yeah.
Whether they lose weight or not, they improve. And I cannot.
They improve metabolically separate from the weight.
Yep. Sorry.
So this woman had three failed IVF. She's a social media influencer. She's told the story about us, so I can share it. She had, failed IVFs. All of her embryos were bad. They didn't grow. And in prep, I said, you have PCOS-like features and your BMI is elevated. And I put her on this diet. And she's like, well, I've done keto before. I'm like, no, not like Twitter keto. We're going to do this version. Protein prioritization with carbohydrate restriction and fat ad lib. And while we were prepping her to do her next IVF, she got pregnant on her own. And so and I've had patients with you where, as I'm doing this with the woman, the man's so sick, they have reversed diabetes, and their doctors told them that that's impossible. And they got off their meds. We have patients that have lost, 100 pounds doing this. And there is data that success rates are better. So obese people, even if they don't have PCOS, have lower pregnancy rates when they do IVF. In my experience, I use this kind of dietary intervention and it works incredibly well. And so I've done this myself. I mean, as you know, like I have followed since my mom was a patient of Atkins. I struggled with being overweight when I was younger, and my whole life, even now. And I have think I've been on low carb diet for 30 years. And I've eaten typically, I never liked eating breakfast and I worked through lunch. So I ate one meal a day. And so I've done low carb and intermittent fasting probably in some form for 30 years. And in the last couple, in the last couple of years, I go off of it when I'm stressed. You stress eat, not when you're hungry eating. Um, and I lost 40 pounds. I've never been diabetic. I wear a CGM because it's my truth device. Am I eating something I shouldn't be eating? And it shows me that my blood sugar goes up when I'm under stress. And I have lost weight and I'm healthier and I've sustained it. So I know it's possible.
Yeah. To what degree do you think, your own experience sort of seeing mom, your own, dieting with the low carb approach, and losing weight and, to what degree do you think this helps you empathize with, the men and women sort of coming to you for help with fertility?
It's huge. You see how hard it is to struggle with something that's chronic where you feel like it's beyond you and you don't have control. But when you get the tools, you see it's the tools. It's, what I learned from you is, you know what? You're not eating because you're hungry. You're eating because you're stressed. Like that Japanese kuchi sabashi, lonely mouth. You're eating because, you know, something's going on. And I can empathize with the patients and I know how hard it is and how they struggle. And I can, partner with them. Your doctor should be your guide, your Sherpa through the experience, not the person who's blaming you and shaming you when things don't work, that it's your fault. And that's what your process. I mean, the coaching, we have the health coaching the same as you do to guide them through that. We have the helpline when things are wrong. Patients call us for help like you do. When we transfer their embryo, we have them do a meditation, a guided meditation to relax them. And we tell them what to eat and what not to eat. And I can relate to them with that.
Can I tell you, I think there's a superpower in patients knowing that you struggle the way they struggle, you're fighting the way they're fighting, and you're working hard to not just be that reflexive doctor that you see in your field of fertility. I think there's something to that. Just you being, genuine, and you see that online. I love the TikToks where you just go through the reality and I don't think your intention is to put down the field, but sometimes the answer is just take some time and thought. It's that simple.
I mean, there's a reason we call it our family reunion, where we invite our patients back. And we have over 600 people come to this every year. And some of these kids are in their 20s because they're like, you changed my life and I'm here with you forever. And your interventions and the things we do, some of this metabolically is saving their life, but you're on their side. You walk with them.
You know what? I may have to take that family reunion. I know I've seen the pictures, just amazing. One of them was so heartwarming. It wasn't too long ago. I know your family reunion, and you see this picture online of just countless people, and that's real medicine. Actually touching people's lives, keeping those connections going.
But what we share is like also, how many patients have you treated like we have, where they were told you can't be helped? We have a patient, we have a video with her. She struggled, for 25 years to get pregnant, 6 places in 3 different countries, told that it's impossible. And we just found what they missed and fixed it. Patients who you've seen that they tell you can't possibly lose weight. The empowered patient can find the tools and the right doctor to help guide them through it,
100%. I think patient empowerment is if I can echo the theme of the last, 45 minutes, hour, it's how do we empower patients? And certainly the other side of it is how do we, struggle to be better? I have to echo everything you said about the utility of health coaching, being there for their vulnerable moments, not eliciting shame, helping them, thinking things through, double checking, shifting when things don't go the way that you are, being persistent. I cannot tell you, I bet you can tell me, case after case, that just took persistence, right? Trying something, adjusting, trying something, adjusting. I know the field of fertility, and I know it takes persistence, and it doesn't take doing the same thing again and again and billing insurance.
That's just sort of unfortunately the sad side of it. But it's, it's the same thing, you'll get your third stent when you have rather than tell them to stop eating sugar, it's, so it happens in every field, but in fertility, it takes a lot of time to guide people and make them healthy and figure out what was missed. There's always a cause. We always say in everything in medicine, nothing's just bad luck. There's always a cause, but we may not have found it yet. We may not be able to find it, but if nothing's ever just because or bad luck, there's always a reason that you can look for.
I'm sure there's people all over the United States listening to this, and I know people worldwide come and see you in your office in Long Island. So 50,000 people are going to listen to this. Maybe 100,000 people are going to be listening to this. Half of those will be female, maybe a little bit more. And, as you said, the rate of PCOS and infertility is certainly increasing. For the listener who's not going to be able to come see you, and is going to have a doc in the box owned by a, hedge fund or private equity, what is it? How do we empower those people? What do they need to know?
Yeah.
Struggling with their infertility, PCOS, hormonal issues, what is it that you want them to know before they walk into one of these offices?
Well, I would tell you, we have I made a book for this that we give away for free. It's called Get Pregnant Now. It's everything that you need to know if you have a problem, how to get tested, and how to find the right doctor. We give that away for free as a service because I can't treat everyone. If you follow me on social media at Stephen Palter, MD, if you go to my bio on Instagram or TikTok, you can get a free download for the book. It'll give you those questions to ask. We're developing a program now where we're hoping to be able to guide people who aren't our patients through these interventions. But what you should ask is go in saying, find a diagnosis. What is my treatment plan and why are you doing it? What's the expected success? And if it doesn't work, what's the reason and what are the alternatives? That's the questions you have to ask. Make sure it's a board certified, make sure it's a board certified reproductive endocrinologist. And even if you don't have a doctor, even if you don't have someone and you're trying to do this on your own, you can look for, improve your health. So reduce weight, try low carb, stop smoking, get pregnant earlier rather than later. Fertility goes down dramatically over 35. If your husband smokes, your partner smokes, get them to stop. If either one of you stops, those things can get you started. And then, look online for the information to know what basic tests you need. There's very few tests we do. We can check if the tubes are blocked with an X-ray. We can check if you're going through menopause with one blood test to tell you if you're running out of your eggs. It's called AMH. We can see, are you going to run out of your eggs, and get a sperm count on the man. In 1 hour, you can find out almost all the causes of infertility. But be careful of all the social media influencers that just want to sell you supplements. Buy these 10 supplements, no matter what your diagnosis is, and everyone will get pregnant. Well, if someone's giving you a drug that's either a supplement or a drug without testing you, and they're just selling you stuff without figuring out what's wrong, then they're as bad as the doctor that just wants to do excessive IVF.
Yeah, I mean, I have seen it. This is a very vulnerable population. So if you're out there and you have infertility, seek out great help. And these resources seem like absolute winners. I cannot thank you enough, Dr. Palter, for coming on. You guys can reach him. Just help remind me, it's Stephen Palter, MD, on all platforms.
Yeah, it's on everything. I am on TikTok, Instagram, Facebook. I mean, I should just tell you briefly why I did it. I was running the largest educational event for physicians. We were running seminars with 5,000 people from around the world where what I developed for the journal was, instead of telling people the answer, we put 5,000 people in a live chat where we used AI to mine the information and tell the experts where the data doesn't match, challenge the dogma, challenge it. And then all of a sudden, my patients I saw were all coming in and doing stupid stuff. I was like, why are you taking this crazy thing? Or we gave you this drug and you didn't take it, or you're you're doing something that makes no sense. Why did you then? Like, well, I saw it on TikTok. I saw it on TikTok. I saw it on Instagram. An influencer told me to buy this. And I said, well, if people can sell misinformation online and reach that many people, then let me go provide education. And so I did it, and, had 100,000 people, within a year. And, we have 165,000 on TikTok, 100,000 on Facebook, with 10,000 a month going up on Instagram, because we share the information, and the patients know what's wrong and they know the questions to ask. And I went to social media because I said, I'm going to put out everything I know and all the questions to ask to help empower them.
Can I be honest with you? Social media is such an amazing tool to get information out there. And I'm 100% with you. It puts the person in the power seat to sort of absorb that information. And they get these resources that they can go to. I've benefited from watching your TikToks. So
as have I for you. I mean, after doing keto for a decade, when I plateaued and was regaining weight, I learned the tools from, that's how I found you. I learned the tools and the tactics of the changes to make. I was working with my trainer. I started doing exercise for the first time in my life. Had never done it. I've gone for 2 years now without a break, and I couldn't get a deadlift right. I didn't know how to do it. And I watched a 30-second video. And after working with a guy for a year, I said, hey, what about this? And he's like, yeah, let's do it. And it worked. You taught me how to, eat when you're hungry and eat till you're full. What a crazy concept.
Yeah, to reasonably flourish. So you're deadlifting, low carb, fasting, deadlifting, key to success. I'll agree with that message.
And it works for our fertility patients. I mean, we do this with them, and we test them. Not everyone's the same. Don't just, but these are powerful tools.
100% agree. Thank you so much.
Oh, thank you for having me, Tro. You're the best.